Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from UCB Pharma, Inc.
All right, welcome everyone. We're going to get started right on time. So we have a very nice program for you called The Clock is Ticking, Optimizing Ongoing Seizure Response. All right, so I'm your moderator. I'm Larry Hirsch, a professor of neurology at Yale University in Connecticut in the United States. These are our faculty, Dr. Retta Kalviainen. She's the professor and chair of neurology and director of the Kuopio Epilepsy Center in Eastern Finland. We also have Manuel Toledo, associate professor of neurology at the University of Barcelona and the director of the epilepsy unit at the Vall d'Hebron Hospital in Barcelona. You'll also see some special appearances by Sun and Amy Park, a patient and patient interviewer. So here's our agenda. I'll start out with some basic definitions. Then you'll hear about the epidemiology of seizure clusters and prolonged seizures. Then you'll hear a discussion on, are we fast enough to prevent seizure emergencies? And then wrapping it up about achieving rapid and early seizure termination. And then our discussion panel. So without further ado, let's get started. So starting with some definitions. The first point is that, as everyone knows, most seizures don't occur in the hospital, they occur at home. And it is extremely useful for patients to have something they can administer in the home setting. The vast majority of seizures resolve in 1 to 3 minutes. Even convulsive seizures, the convulsive phase is usually 2 minutes or less. But a good portion of patients still experience seizure clusters or prolonged seizures. And you'll hear a little bit more about the prevalence in a minute. So what is a seizure cluster? That is now the preferred term for this. It's a series of seizures that have a short period between them. Some of the most commonly used cutoffs are 3 seizures in 1 day or 2 seizures in 6 hours. There are statistical definitions as well, meaning there's either a 3 or 4 times the usual rate of seizures. And then there's many synonyms for seizure clusters, including the phrase acute repetitive seizures, which is the one used by the US FDA, but also seizure flurries, serial seizures, crescendo seizures, etc. And a seizure cluster is not an official category in the ILAE classification. So what are prolonged seizures? This might be a somewhat new concept and term to some of you. So it's defined as a seizure that's longer than typically occurs, but not long enough to qualify as status epilepticus. So a reminder, status epilepticus is defined as 5 minutes or longer of convulsive activity. That means prominent motor activity with impaired consciousness. And for all other seizure types, it's 10 minutes. So a prolonged seizure is defined, the suggested definition is more than 5 minutes for a focal seizure, more than 2 minutes for the convulsive phase of a bilateral tonic-clonic seizure, and greater than 2 minutes for an absence seizure. Another term is rescue therapy. So that's any non-maintenance therapy that's given to abort a seizure or a cluster. So it can be a medication, but it can also be another intervention, such as an extra stimulation from a neurostimulator or neuromodulation device. Rescue therapies or rescue medications can be used for 2 different reasons. One is to abort a seizure cluster, meaning to prevent the next seizure. And the other use is to actually abort the ongoing seizure. And this is referred to as REST, or rapid and early seizure termination. So that is terminating an ongoing seizure. All right, time for your first polling question. With that, I'm going to let Dr. Toledo take over and talk about epidemiology.
Yeah, thank you, Larry. So thank you to organizers for inviting me to come in here and the Congress organizers as well. So I'm going to talk a little bit about epidemiology of the seizure clusters and prolonged seizure, which is something that is not that easy because the definitions has changed across the time, and then we have shortened sometimes for the status epilepticus, and then the definitions of the clusters is still not definitive. So when we go to the studies that they establish potential prevalence of prolonged seizures, all of them refer to seizures lasting more than 30 minutes, basically status epilepticus, and in the adults it's supposed to be around 0.5 to 1.6 every 10,000 people. And then in children, a little bit higher, like 2 every 10,000 children, and probably related to the presence of febrile status epilepticus. In the North London study, the febrile status epilepticus and then acute symptomatic seizures account for more than half of the patients with prolonged seizures, and 12% of them had seizures, epilepsy. In the Yale prospectivist cluster study, they define the cluster of seizures as 2 seizures within a 6-hour period. And they found in those patients that had active epilepsy with at least 1 seizure in the previous years, then 2/3 of them may have another seizure cluster during the follow-up. We will talk about that later, but the consequences of the seizure clusters and prolonged seizures are the increased risk of status epilepticus, like convulsive status epilepticus occur in 44% of patients with seizure clusters. The increased risk of premature death, according to CLAMPA studies with a follow-up of patients in Finland during 40 years that they started epilepsy during the childhood. The risk of more premature death was 3.4 higher than in the rest of the population. And finally, as assumed for everyone, the risk of seizure increase, and it's an increasing curve of risk, and 22% of patients that had at least 1 lifetime seizure cluster increase more than double the risk of SODOP. In this study, they studied those patients with febrile, children with febrile status epilepticus or febrile seizures, where 193 had a febrile status epilepticus, and they found that those patients that presented with a febrile status epilepticus had a higher likelihood to have a recurrence during the following years. And additionally, they suggest that abnormalities in the MRI was a risk factor to have a prolonged seizure, another febrile status epilepticus. And then a minority of children with a first febrile seizure was treated, or status epilepticus was treated with abortive therapy. And in those patients that use rescue medications, there was a significant reduction of seizure duration to less than 5 minutes. Going back to the epidemiology of the seizure clustering, we all know probably as a patients, as a physicians, as a medical professionals, what is the seizure clustering when the patient comes to the visit and tell us, doctor, I have this seizure frequency, and look at my diary. I have a group of seizures on one day, in some hours on that day. It's easy to identify, but probably it's difficult to define. That's because it's difficult to know what is the real prevalence of seizure cluster across the population. So overall, let's say that it's approximately 20% of patients with epilepsy suffer seizure clusters. And then if we move into patients with drug-resistant epilepsy, it increases up to 23 to 46% of the population. And of course, in patients undergoing pre-surgical evaluation, it's up to 60% of them has suffered at least one seizure cluster. And so this is the next slide. Yep.
Okay, so next we're going to hear from a patient.
Seizures and when they started.
Sure, I had my first seizure 21 years ago from unexplained inflammation in my brain. Since then, I've had 6 brain surgeries, and I'm still not controlled by medication.
Son, what type of seizures do you have? And can you tell me what they're like?
I have focal motor seizures that start on the right side of my frontal lobe. And then it presents as twitching, jerking, and shaking along the entire left side of my face, arms, and legs. I'm conscious so I can feel the electricity pulsing throughout my body. It really hurts. I can also see and hear everything because I'm aware. So I'm aware of what I'm feeling and what I'm seeing and how people are responding. So for our family, seizures not only affect me, but we live with epilepsy. When I have a seizure, I can see you and our kids watch my body to respond for my seizure medications to slow down the seizure. I can hear my daughter say she'll turn off the lights so the lights are not shining into my eyes. Then I can see that she steps aside because she's so scared. I think she has the hardest time with my epilepsy. I can also hear my son keep track of the time, saying it's 5 minutes, 10 minutes, and I can take my second rescue medication. And I can feel your right hand holding my non-seizing hand, reassuring me that my left leg is stopping or my right arm is slowing down, or the twitching is going away. At that point, if we call the ambulance, I know it's been a long time, and I'm probably going to the hospital. But no matter what, it feels like forever. I lose track of time, and it just hurts.
How long do your seizures last, son?
Well, every seizure is almost different, but on average, they can last from 3.5 to 10 minutes. And if they're not stopped, then they can go for 2 hours. The longest seizure was 3 hours, but I'm fortunate that I don't have generalized seizures, where there's oxygen cut off my brain. But I'm unfortunate in that I have prolonged seizures that aren't responsive to medication.
Son, why is it important to stop the seizures as soon as possible?
Other than it's really painful for me and scary for anybody watching, especially my family, the longer the seizure lasts, the harder it is to stop the seizure. And when a seizure lasts for longer than 10 minutes, we have to call the ambulance and go to the hospital. And even though they can give me IV rescue meds, it takes more medication to stop the seizures. And by that time, I'm heavily medicated with these other concerns, like my breathing, the longer it takes for my body to return to baseline. Then they have to monitor my breathing. I usually have to stay in the hospital so they can monitor a seizure if it comes back or not. And the longer I have a seizure, the more likelihood that I'll cluster. So I'll have frequent ones as they end.
So, son, what happens after the seizures with your doctor?
Whenever I have a seizure, I let my doctor know right away because he has a plan. I may want to adjust my medications. You try to figure out if there's a clear cause for the seizure. Sometimes there isn't, but I'm assured knowing that my doctor always has a plan.
Son, how have rescue meds impacted your life?
In so many ways. Before we had rescue meds, it was almost as if we were hoping and praying that the seizure would stop. And I wouldn't even go out sometimes because I was so scared. But now that we have something, I carry it on my person all times. I have a label so that people, if you're not there, that people can use it. And I'm able to have a little more freedom just to go out and not worry about the seizure stopping or not.
Son, is there anything you want to add for neurologists to know?
Well, as a person living with epilepsy, I'm trapped in my body, and I have no control over when the seizure happens, how it happens. It's all uncontrolled and uncertain. But that uncertainty is diminished by having a great neurologist who understands me, knows my history, and has a plan for treating me. He knows every single seizure drug we've tried and the side effects I've had. He's viewed countless images of my MRI scans and EEGs. He knows my seizures better than me. What I respect most of all is that my doctor acknowledges that he doesn't know what it's like or how it feels to have a seizure. I appreciate he's doing his best to help me with my seizures. He reassures me, and I trust him and his decisions he makes about my treatment plan. I don't research the web because I know that my doctor knows everything there is to know about seizures and mostly my type of seizures. He not only reassures me, but he also reassures you and our kids. In fact, the kids joke that about his retirement plan, which we hope isn't anytime soon. I understand that the cure for epilepsy may not be in my lifetime, and so me and my family have to live with seizures. But it would be great if there was a faster, more effective rescue medication that can help stop the seizures as soon as possible. Because like I said, they hurt a lot.
All right, so that was really a beautiful description of just life living with epilepsy, not only as a patient, but you see the effect on the entire family and on the important role of rescue medications that already exist. As he said, he's much more comfortable going out in public and doing things now, but also clearly leaving a lot of room for improvement. We still need something that is more effective and faster. But I do want to thank Son and his wife Amy for making that video. We give him a big round of applause for that. That's much appreciated. So thank you. All right, we're going to move on to Professor Kalvianayan. She will talk about, are we fast enough?
So I also want to thank Sun Park for this excellent epilepsy experience expert statement, which really nailed it, I think, what we are talking about. And it's a little bit difficult to continue from that. But a really important topic, are we fast enough to prevent seizure emergencies? He already pointed out why we need to do this, but of course there's also the point that prolonged seizures and status epilepticus lead also brain damage, and we all know that there's this cascade of selected mechanisms leading to the exotoxic brain damage, which then, of course, the risk increases if the seizure prolongs, and this is a couple of the mechanisms in this slide which lead to this damage. There are, even in the beginning of the seizure, when it turns to prolonged seizure, there are neurotransmitter releases, receptor trafficking, which is very important. Even in minutes, we start to find decrease in inhibitory kappa A subunits, and then increase in NMD and AMPA receptors. This is a very important point where we would need to tackle. And then within minutes to hours, there are neuropeptide expression changes, and within days and weeks, there are also genetic and epigenetic changes, and the seizures become, of course, more resistant to our treatments. We already heard what are usually the length of different seizures, and we luckily now have more and more evidence, for example, from video EEG analysis from video telemetry units, that usually normal seizures don't last more than 1 to 2 minutes. So it's already abnormal if it lasts longer, and the likelihood of self-termination is then decreased if the seizure lasts longer than 2 minutes in many of the seizure types. And again, the likelihood of irreversible tissue damage, of course, increases. And this we already know. And again, benzodiazepines are the first-line treatments that we use, and at the moment, those are the only drugs that we can use and are available. But it's very important to understand that we already have a lot of evidence that patients who receive the first-line benzodiazepines treatment in less than 10 minutes, but earlier the better, they are more likely to have a shorter status epilepticus episode, and even not status epilepticus at all. So we should aim towards decreasing the time period for using these drugs. Not always easy, of course. And there are studies showing that the probability of seizure stopping also with treatments, it drops rapidly for the after the first 5 minutes. And the reason is one of the mechanisms related to the prolonged seizures and status epilepticus, which is the internalization of kappa-A receptors, and together, of course, with the NMDA receptor increase, then leading to the drug resistance. There are other mechanisms also, but this is the most important that we need to know and think about, and teach also others. Now we are here, but when we go back home, you need to make people to understand why this is so important, to act quickly, and there's also a mechanism behind it, why this is important. ILE defines status epilepticus time point T1 when the status epilepticus is not going to probably end without intervention, for example, for tonic-clonic seizures at 5 minutes. But now we have had this kind of consensus group doing modified Delphi-based consensus process, and this has been published last year. The group had both adult neurologists and pediatric neurologists from US and Europe. We are part of that group, and we really discussed and then also went through this quite laborious Delphi process and thought about when would be really the time point for prolonged seizure, which is different from status epilepticus. So then, for example, for tonic-clonic seizure, we thought that it's 2 minutes, absence seizure when it's over 2 minutes, and then for focal seizures, we estimated that it might be 5 minutes. So prolonged seizure is different from status epilepticus T1. And why this is important? The current recommendation to act has been, for example, for tonic-clonic seizures, 5 minutes. So that is happening when we have been discussing this. This is still happening, that when we then give rescue medications for families and patients. The instruction has been, according to this status epilepticus definition for intervention, it has been to wait for 5 minutes tonic-clonic seizure. But I think this is one of the most important take-home messages from this meeting or this session, is that if you are in hospital and you have a patient having a tonic-clonic seizure, we don't wait 5 minutes. We give the medication that we have at hand, usually in the hospital, IV medication, we give it immediately. We stop the seizure. So why we have been now giving the instruction to home, to caregivers, something else, that they should wait longer. And probably they haven't been waiting longer. They have acted earlier. So we should now change our advice to act earlier, or even earlier than the prolonged seizure, 2 minutes for tonic-clonic seizures. There might be a window of opportunity even in those patients that we know that they are going to be having prolonged seizure. We could act even earlier. Therefore, the patient testimony or expert opinion that we heard was excellent. He already told us in their case what they could do. He has prolonged seizures, but they know that they are going to be prolonged. They can act already earlier. So when there are these focal preserved consciousness seizures that then can get prolonged or can develop into more serious seizure types, there is a window of opportunity to act earlier if we have medications. And we do already have some rescue medications, but hopefully we are going to have even better medications for that purpose. And of course, there are also generalized epilepsies where there are flurries, repetitive myoclonic jerks, which then develop into tonic-clonic seizures, juvenile myoclonic epilepsies, progressive myoclonic epilepsies. So you can start to act earlier than we used to think. So this is what we already heard. We now call it rapid and early seizure termination, a new concept that has been discussed in many groups of experts, but also in this consensus guidance article that I mentioned by Pinakasia et al. Last year in Epileptic Disorders 2024. And what we suggest that REST should be used, it should be offered to all patients that already we know that experience prolonged seizures or seizure, like Sun Park that already told his situation. And of course, to all patients that have experienced already status epilepticus. So this is really, really important. And then how this rescue medication or rest medication should be then administered, when it should be administered in these patients. So as early as possible. I'm quite confident that patients and families start to recognize these situations, and they also know when not to use it. They start to, and they usually recognize the situations where the seizure is not going to be so serious and prolonged if there are lots of seizures. What this means that we need to talk about more acute situations, acute seizures. We need to educate general audience about first seizure aid, and also then for individual patients, we need to give urgent seizure plans. So, which means seizure action plans or acute seizure action plans. There are different names for these plans, and there are models and examples available in internet. And the goal is also, it's very practical, what I said, to empower the patients and caregivers to give first aid and also give these medications if needed, but also the other point is to reduce anxiety and fear about seizures. And altogether, this might really decrease risk of status epilepticus, risk of hospitalizations, and mortality. So this is what all epilepsy patients should have. They should have a plan, this seizure action plan. It could be in the mobile phone, where there's a place for emergency contact info. There could be very short personal information, contact info, information about the seizure types and medications, and where to contact if the seizure happens, when to call EMS, and other urgent care situations specific for that particular patient, and when to contact neurologist after seizure. We are not talking that acute, we are not telling you that acute treatment should replace chronic treatment. So of course, when seizures start to happen in a seizure-free patient, you need to contact also later on to the neurologist to make a better care of your chronic treatment. But for these patients, probably the urgent seizure medication is needed only for specific situations. For example, when you travel to rural areas or something like that. But then for those patients who do have these prolonged seizures or who have drug-resistant epilepsy, in addition to seizure action plan, you need then urgent seizure plan, where you then define when to, together with the patient and the family, you define when to use the urgent seizure medication. So what is the situation for rest in this particular patient, or if they are in need for acute cluster treatment. And again, when to call then EMS, when to consult and transfer, where to consult and transfer, what's the particular hospital where this patient should be referred, and again, when to contact neurologist after seizures. So this is something that we should pay attention much better also in our comprehensive care of epilepsy patients, doing these plans individually. So it's not all the same minutes, all the same situations for every patient. What is the current situation regarding the medications? In the hospital, IV is the golden standard. If we have an IV route, then the bioavailability is great, nearly 100%, and time to peak is quick, and that usually starts to stop most of the seizures quickly if given early enough. But that's not the case, of course, because these seizures happen, as Larry said, these happen home environment, and then the options are less effective, time to peak much more longer, and bioavailability also varies. So we have intramuscular options, oral options, rectal options, buccal options, intranasal options, and then we are going to talk more about new inhalation option, which starts to then be near time to peak blood concentration, it times to approaches to IV option. So this is the approved seizure rescue treatments at the moment, but these drugs are not available throughout the world, of course, globally. So diazepam rectal option is something that is not so much accepted by the patients. So nasal option, diazepam and midazolam, has in some parts of the world, like in US, now replaced it quite much, as then in Europe, for example, where EMA has approved midazolam. Buccal option in Europe has replaced a lot of use of rectal option. And these are already, I think, changing the scene and also already decreasing the hospital admissions if used in a right way. But there's still a gap between the option when we can really use, for example, diazepam or lorazepam intravenously, and the time to action is really, in most of the cases and situations, totally different if we have IV possibility. And that kind of situation or drug would be the ideal. So what we hope and what we heard the patients would also wish to be the properties of an ideal rest medication is that it would be effective against all seizure types. You don't have time to think about which seizure type this is now at hand in these kind of acute settings, or if the person is not professional to estimate or evaluate what the seizure type is. It should be non-invasive, easy route of administration, and it should be also be possible to administer it in a peri or both peri and intraictal outpatient situation. It should be portable, it should be easy to use, and as said, the absorption and time to action should be equal or nearly equal to IV drug delivery. And of course, rapid onset of anti-seizure activity in order to be able to stop the seizure. And this is my last slide. What is now the future at the moment, or hopefully the future is much more, but at the moment we have already some status epilepticus options that have FDA orphan drug designation, midazolam needle-free transdermal injection, and midazolam intramuscular auto-injection, where the estimated time to rest effect, rapid seizure termination effect, would be 3 minutes. That's not bad, and quite easy administration. But then there's also alprazolam, oral passive inhalation of heated drug vapor, and that's quite similar now regarding the time to rest effect to IV benzodiazepines. So 30 seconds is the estimated time to rest effect, and this is now one of the only drugs that is under development for rest indication in phase 3. And now you can start to then answer this polling question, and I move to Larry. Thank you.
Thank you, Retta. That's a great overview.
Okay, back again here. So achieving rapid and early seizure termination. Management of seizure clusters and prolonged seizures in the European Union. There's a high level of agreement on the recommendations for defining and managing prolonged seizures and seizure cluster. The rescue medicines are only approved or indicated is prolonged seizures with no time frame, or more than 3 seizures in 1 hour. That's based on indications of the different options. If 1 seizure or more prolonged seizure, it's administer rest medication as early as possible before the seizure becomes prolonged or enters into status epilepticus. The rationale for this coming from the basic science to the social impact. We can say that the risks associated with seizure cluster and prolonged seizures are irreversible neuronal damage and late epileptogenesis, like I've seen in animal models, or some kind of a human experience, not that evident, but it's likely that it can be produced. The more frequent emergency department visits and hospitalizations with patients who suffer this type of seizures. There's an association with the status epilepticus. Status epilepticus is basically about time that you consider an ongoing seizure and a status epilepticus. There is an obvious reduced quality of life for both the patients and the caregivers that they need to be just by the patient side because of the risk of prolonged or recurrent seizures, predisposed to psychiatric and physical comorbidities, has, as I explained before, higher premature mortality and increased risk of setup. Can they be the cluster predictable? It seems like the risk factors for being a clusterer, which is easy, is to have drug-resistant epilepsy or having a history of clusters, prolonged seizure, or status epilepticus, or as we say before, children with focal febrile status epilepticus or atypical status epilepticus. But not all patients with drug-resistant epilepsy are limited to this risk population. There are some periods of vulnerability. Probably some of you with epilepsy that had traveled overseas to come to Lisbon just for a couple of days and come back maybe to 6 hours back and forth will feel a little bit safer if you have something in your handbag that can stop a seizure if you start feeling something in the next couple of hours. So those are periods of vulnerability. So there are like the abnormalities, so changes in the wake-sleep time cycle, periods of stress, fever, or illnesses like infections, oncologic treatments, missing or modifications of the anti-seizure medications, of course, the use of alcohol or drugs, and in some cases, catamenial epilepsies during the menstrual period. Do we have contraindications for rest medications? Really not big ones. So contraindications for benzos, that should be the ones. And then it's something that we have considered is that we always need to balance the potential benefits of prescribing a rest medication in those patients with epilepsy or with an epileptic syndromes that they have so often prolonged seizures, like daily, several times per day, that having that as a weapon against the seizures doesn't improve the whole picture, and it doesn't improve the prognosis of the seizure or the epilepsy, because right after the patient is going to have another seizure like that. Coming back to the medications and the alternative we have rescue medications for seizure cluster. The route of administrations is several mucosal administrations, nasal, rectal, oral. We'll come back to it later, or IV. But then the reality in the epilepsy community is that the rescue medications are underused in patients with a seizure cluster, and then less than half of the adult patients with seizure cluster are prescribed benzos as a rescue medication. In the consensus recommendations in the management of seizure cluster and prolonged seizures, the rest is a new paradigm for treatment ongoing seizures to prevent higher level of emergencies. The acute cluster treatment proposed as a new term to describe medications used to prevent the next or further seizures in a cluster of seizures. There's a clear terminology defining prolonged seizures and seizure cluster to aid the identification of patients who may benefit from early intervention. An effective early administration of rest medication or acute cluster treatment will rely on a viable discuss with the patient and the caregivers. The balance is benefit. In Spain, we made a consensus because we had that the seizures, the spontaneous seizures usually resolve, all of them, all seizure types, resolve usually within 2 minutes, no longer than 2 minutes. So they are always usually shorter. And then that the seizures usually occur in the home setting, in the work, in the residency, in the school. So we need to make recommendations for patients, caregivers, and the facilities and the venues where the patients live to use these medications, these rest medications. So it was easy when to apply these medications. Let's say 2 minutes, 2 minutes in general. So if a seizure lasts longer than 2 minutes, in general, this rest medication should be applied. Or if a patient has 2 seizures within 6 hours or 8 hours, or doubles the seizure frequency within that time frame, we should apply that acute clustering treatment. To whom should medications be prescribed? As we discussed before, patients with drug-resistant epilepsy, history of status epilepticus, febrile status epilepticus, and so on, should be prescribed on any of these alternatives. Patients with epilepsy that show preictal signs, or as sometimes patients describe like weird sensations, psychic sensations before they are going to have a seizure, or even in some type of epilepsy, patients with generalized tonic-clonic seizures, they feel like myoclonic jerks before, or absence. They could be, we could apply that treatment in these cases to abort the progression of the seizures. And then in selective patients who are in the process of withdrawing or modification of anti-seizure medications where a breakthrough seizure, prolonged, or a cluster of seizure may come up. Who should administer the medication? As I said before, healthcare professionals, easy, of course, any. So it's not an issue that we have different alternatives, and we are in a hospital with an IV formulation. That will be the best one, probably. Patients, it's not that easy, that is not that common, that patients are able to self-administer medications before a seizure, but maybe if they have time, or they are aware of the situation and they are able to self-administer an easy-to-use medication to abort the seizure, that should be an option. The ones that always support us, which are family members and caregivers, and they often know better than us how to apply and when to apply these medications and to abort the seizure or the complications. But then the important thing is the authorized staff. We need to authorize and describe and prescribe precisely for each patient how to administer the medications in the school, residency, leisure centers, sports centers, everywhere where the patients used to go, and there is authorized staff to administer these medications. Within different alternatives, we have inhaled alprazolam for the rest. It's a rest medication, which is an alternative under development that hopefully will come up to the market soon. And it has the whole characteristic required to have to be a rest medication, which is easy, safe, quick, and hopefully effective enough as to come up to the market. So if we go to the results of the phase 2 trial with inhaled alprazolam, which is not really, the patient doesn't have to cooperate. So the importance of this treatment is that the patient needs just to breathe, to be alive. And then the medication goes and spread into the lungs. So here, in the phase 2 study with 116 patients, the primary endpoint was to achieve a seizure cessation within 2 minutes after the treatment, and no recurrence after 2 hours. 2 hours was higher in those patients that were used alprazolam at 1 milligram or 2 milligrams compared to placebo. At the median reduction time in the seizure duration was 30 seconds in the patients with, treated with alprazolam compared to the placebo patients. If we go to the recurrence, to the risk of recurrence in the follow-up, so the patients that were treated with alprazolam, they have less recurrence, of course, during the next hours than the patients that were with placebo, treated with placebo. So regarding safety, which is basic for using these treatments in the home setting, maybe for a known relative of a patient, is the 66% of treated patients were responders. It was well tolerated when administered as a single dose of 1 or 2 milligrams. The most common adverse events was cough and somnolence, followed by dysgeusia. The intensity of adverse events were all mild to moderate and no treatment-related serious adverse events. We have coming back to other medications that Rita reviewed them. We have subcutaneous, intranasal, rectal. All of them are useful or could be an option for as a rest medications. However, all of them have problems and are not that much available or not much suitable for all patients with epilepsy, as all injections, subcutaneous or intramuscular or IV, need to be administered by medical professionals. Rectal is useful for children, babies, but not for adults. The intranasal buccal may be the most popular at the time. Patients usually have hypersalivation. They need dose adjustment because the doses coming in is not exactly what we cannot estimate the doses that really achieve the brain. Ictal symptoms like chewing or a clenched jaw limit the use of these drugs. And then the intrapulmonary way, as I said before, is a safe way to arrive to the brain, crossing the lungs, and the distribution of the drug and the doses is pretty much adjusted and effective. And here we move into the next polling question.
Okay, thank you. The first one is correct, and the other three are incorrect answers. Okay, so we're going to move to conclusion and wrap it up, which we will do fairly quickly. I'll just make a few final comments. So just to summarize the definitions, we went over the definition of seizure clusters, of prolonged seizures, which may be a bit new, and that's defined as more than 5 minutes for focal seizures and more than 2 minutes for convulsive phase of a seizure or for absence seizures. And we went over the definition of the new concept of REST, or rapid and early seizure termination, where the goal is to stop an ongoing seizure, not just prevent the next one in a cluster. So we went over the prevalence, where clusters and prolonged seizures are very common, really in anybody who still has active epilepsy, and even sometimes in some other patients. So we've seen that prolonged seizures and seizure clusters increase the risk of many adverse effects, both on the patient, the caregivers, the whole family, as we heard from Sun in that video, on the medical system. It's a risk of status epilepticus, emergency department visits, injuries, psychiatric issues, sudden death in epilepsy, lower quality of life, and lost time at work and school for the patient and the family. As far as management, we stress the importance of seizure action plans and early treatment with rapidly acting agents, and really as early as possible is more and more becoming the recommendation. And we do have good rescue medications available, certainly much better than we had 5-10 years ago, but we still need faster, more convenient ones, and we have some emerging options, especially as far as speed. The inhalational route is looking extremely promising and very close to intravenous. So with that, I'm going to thank all of you for participating. Thank you very much.